Good afternoon, everyone. Myself, Dr. Jaskan. I am working as an EP fellow at Lisi Hospital, Kochi. At the outset, I would like to thank Dr. Ajit Thachil sir as well as the IHRS judges for this opportunity. Coming on to the case, this was a 51-year-old male with chronic kidney disease and hypothyroidism as comorbidities. He had an old anterior wall MI in 1997. Angiogram showed a recanalized AD. The patient had severe renal dysfunction with a large apical aneurysm. Over the last 6 months, he sustained 3 episodes of VD, all hypotensive and all requiring DC cardioversion. He was on 400 mg of amiodarone and 200 mg of metoprolol before the third episode of VD, which happened in September 2021. This was the ECG of the VD, which showed a RBP morphology, mid QRS transition with left superior axis. Considering the VD was hemodynamically unstable and the patient had a large substrate, we decided to go ahead with the functional substrate mapping first up, followed by activation mapping of the clinical VD, and then delineation of the circuit using entrainment mapping. For isolated potentials, as we could see by the figure on the left, there are some late potentials, but they are minimally delayed. However, on RV pacing, those same potentials they get significantly delayed, and they are at the end of the QRS. So we created a isochronal late activation map using RV pacing, using multipolar mapping with HD grid catheter. This was the area of earliest isochrone at the inferior septum, from where the RV impulse activated the earliest part of the LV. Then we could see late isochrones with a potential with a QRS to potential delay of around 280 milliseconds in this area, and we could see the area of latest isochrone represented by purple, where a delay of 300 milliseconds was present. And most importantly, we could see the area of this red meeting purple. This was the area of isochronal crowding. On seeing the electrograms in the area of isochronal crowding, we could see these continuous signals which represent conduction delays. And this zigzag discontinuous conduction could be either through the endocardium or it could be the circuit going from endo to myo to epi and then coming back. We observed another similar phenomena in the adjacent zone, where we could see that with RV pacing, there were variable local lead to potential delays, as represented in this figure. This could possibly represent conduction going through different channels, and then hence the variable conduction delays. Subsequently, after making the map, we decided to induce VD. We could induce two VDs, VD1 being the ill-sustained one and VD2 being the clinical VD and the sustained one. Both were quite similar to each other except the QRS transition. VD1 had a more apical exit as compared to VD2. On activation mapping of VD2, we came across this zone which was near the conduction delay into the scar. This zone had mid-diastolic potentials in the A spline as marked. So we decided to entrain this area. First, we kept the pacing output at 11 milliamperes at 1 millisecond. We were able to accelerate the tachycardia. So we wondered whether this was a good area to evaluate. On seeing the intracardiacs, one can see that the mid-diastolic potentials have not been captured. However, the local V has been captured. The PPI minus TCL was 0 and the stim was at the onset of QRS, which was similar to EGM to QRS, suggesting that this was the exit site of the tachycardia. Since we had a mid-diastolic potential there, and this area was adjacent to the area of isochronal crowding, we decided to increase the pacing output. We increased the pacing output to 14 at 2 millisecond and again try to entrain the tachycardia. Again, we can see here we have accelerated the tachycardia to pacing cycle length. There is entrainment with concealed fusion. And now is this a good area to ablate? Now we can see that the mid-diastolic potentials have been captured, and it is the local V which has not been captured. PPI minus TCL was 0 here, and SCM to QRS was equal to EGM to QRS, which was 127 millisecond, which corresponds to 30% of tachycardia cycle length, suggesting that indeed we were at the isthmus of the tachycardia. When we compared the isochronal rate activation map and the limited activation map of VT2, one could see that both areas were adjoining. This was the area of isochronal crowding, this was the area of latest isochrone, and this was the area of the isthmus. All of these were at the border zone of this scar. VT terminated during mapping. Due to hemodynamic instability associated with the VT, we decided not to reduce the VT. The area of isochronal crowding on hilum and the adjacent isthmus side of VT were ablated on the epicoceptal aspect of the aneurysm. No VT could be induced after aggressive programmed extrastimulation using 4 extrastimuli from both RV as well as LV till ventricular effective refractive period. This was the site where RFA was performed. And the patient has completed approximately 2 months of follow-up, and he is currently on tapering doses of methadone. He is right now on 100 mg per day of methadone and metoprolol succinate 200 mg per day. And ICD is recommended for the patient. So my take-home message is ILM are a reasonable way to start in patients with large substrates and hemodynamically unstable VT. Sometimes we have to change the direction of the wavefront in order to see areas with conduction delays. In this particular case, detailed isolated rate potential mapping showing the area of conduction delay into the scar predicted the isthmus of the VT. So essentially VT was exiting out through the indoor. Case highlights the importance of varying the pacing output, as at lower outputs we were not able to capture the mid-diastolic potential, which we were able to do at higher outputs. And of course, the importance of ascertaining the exact potential captured during entrainment mapping cannot be overemphasized. Lastly, a food for thought. As we saw in the entrainment, at the low output we captured the local V, but not the mid-diastolic potential. However, at higher output we captured the mid-diastolic potential, but not the local V. What could be the possible explanation for the same? One explanation is possibly the isthmus was deep seated and we captured that area, but this is just conjectural. Thank you.
So we would like to welcome Dr. Natarajan, who's joined us in this session. So shall we start off by talking to Dr. Azim? Is that okay? Can you hear me, Dr. Azim?
Yes, sir. I can hear you, sir.
Yes. So that was a very nice, elegant presentation, and you very well showed the left ventricular non-compaction, and it's a very interesting case. And I would like to just ask you a few questions in the history that you presented. This man presented with VT and had an ICD implanted previously.
Yes,
what anti-arrhythmic medication was he sent home on at that time?
He was only on a beta blocker, sir. In fact, he was on an inadequate dose. He was just taking 25 milligrams once daily, and he was on that. He was sent home with 25 milligrams of
okay. He was just on a beta blocker. And when you did the investigations, you did a cardiac MRI and very well showed the left ventricular non-compaction and also aneurysmal segments of the LV. What was the logic in doing an LV angiogram? Did you have any more information to gain?
No, so the MRI was actually done at the time of the ICD implant. That was almost 6 to 8 months prior to when we took him up for ablation. So when we took him up for ablation, we just wanted to do an LV angio to look whether there's any change in the anatomy other than subjecting him to a repeat MRI. Because generally for all ablations, we do an LV angio prior to ablation. So we did the LV angio for that reason in this case.
What point of time did you start him on amiodarone? Because you said that he was discharged home on amiodarone.
Yes, sir. He presented to us, he was having recurrent runs of NSVT on the monitor. So once we turned off his device, connected him on, put him on deep sedation, and then once his pressures improved a bit, we started him off on amiodarone infusion along with Xylocard. So
Okay.
he was on, yes, sir. Yes.
So when you took him for the EP study and ablation, he was on amiodarone therapy at that time. So I was just going through your 3D mapping and substrate mapping. That was very sort of elegant, and you have ablated, targeted the late diastolic potentials and late potentials. That was very good. So my only question is that you have not induced tachycardia prior ablation.
Yes.
You have not done any pace mapping, and you have done substrate modification.
Yes.
The patient was already on amiodarone. So just being a devil's advocate, if I say that the VT was non-inducible because he was on amiodarone therapy rather than the ablation, how would you, what would you say?
Sir, actually, when we took him up in the lab, he was still having a lot of clinical ectopy and couplets, and despite being on these amiodarone and lignocaine. And after we completed the procedure, we aggressively tried to induce the VT, both from the RV, LV, two different sites. We also started him on isoprenaline and repeated the protocols on the drug as well. And despite all of that, we were not able to induce VT in this patient.
Sure. So you were not keen on doing a pace mapping?
Since he was hemodynamically unstable, already on inotropes, we, as a protocol, do not generally induce VT as the first line in such patients. We do a substrate mapping in sinus rhythm. And after that, if it is still inducible after completing our substrate mapping, then we definitely pace map in such patients.
Sure. I have no more questions to ask. I'll let Dr. Natarajan.
Sorry, I joined in a little later. Can you hear me?
Yes, sir. Yes, sir.
I was stuck in an emergency. I apologize. Dr. Mohammed, I've gone through your, I've not listened to your presentation, but I've gone through your slides. So I just wanted to ask you, non-compaction also has this mid-myocardial fibrosis on late gadolinium study. Is it known? Unlike a DCM, this also has all the features of non-compaction you have.
Yeah. Yes, sir. Yes, sir. Generally, in LV non-compaction on MRI, they do report areas of late gadolinium enhancement. But the unique thing in our study was it was confined to a single coronary artery territory. Whereas generally in non-compaction, they say that it occurs, it's more of a patchy involvement throughout the LV myocardium. That was one thing. And however, the presence of an aneurysm is again one of the features of non-compaction. As the myocardium starts to, go in towards the end stages, then it starts dilating, and then an aneurysm can also form. So yes, LG does occur even in the presence of LV non-compaction. It has been reported.
All right. Okay, Dr. Venkat, we'll go to the next case. Yeah.
Sure. So
thank you, sir.
Thank you, Dr. Mohammed. So let's talk to Dr. Prezi Varghese. I think that was very nice presentation, and you have presented a case of somebody who's had previous ROS procedure and dual tachycardia. So I just wanted to know, what was the anticoagulation status of this patient at the time when you started the procedure?
Warfarin was going on for the patient, sir.
Oh, okay. The patient was on warfarin. So what was the mapping strategy that you used when you started this procedure? Was the patient able to tolerate the tachycardia VT. So your thought process was to do an activation mapping. Is that right?
So first we mapped during sinus, then we did a tachycardia activation mapping. It was a stable VT, patient tolerated the entrainment.
And you have very nicely demonstrated the isthmus area. What's the general prognosis for these patients, for ones who have had Ross procedure sort of previously? And
So,
yeah.
Yes, so we have planned ICD for the patient. Yes, sir.
But I take that the general prognosis is good in terms of previous Ross procedure and cardiac arrhythmias. Is that right? So
yes, sir. Yes, the prognosis is
a defibrillator because the patient has LV dysfunction. Is that right?
Yes, sir.
Dr. Natarajan, have you got anything?
Nothing. We'll move on. Yeah.
Yes. Okay. Let's move on to Dr. Jaskaran. Thank you. Thank you.
Thank you. Thank you.
That was a very good case, Dr. Jaskaran. That was very informative and very thought-provoking presentation. So I just wanted to know what made you choose this form of mapping, isochronal late activation mapping. What was your thought process in choosing this mapping methodology?
So, the patient had severe LV dysfunction because of anterior wall MI. The whole of the anterior wall and the septum was scarred. So we thought the VT was unstable. All the 3 episodes occurred with syncope. The third one was on drugs, on amiodarone, maximum doses of amiodarone beta blockers. So our first strategy was to evaluate the substrate first, because VT mapping, detailed VP mapping would have required mechanical circulatory support. And anatomical substrate mapping would not have given too much of information, because we already knew this much of area was scarred on echo. So our point was to find the areas of conduction delays, and if we can conclusively demonstrate that if we don't have too many areas of conduction delays, and then we can later prove that these areas of conduction delays are not blind channels, they are in fact participating in the VT circuit, they are a part of the VT circuit. That would be the best way to show, to conclude success. But of course, the only thing that I felt was, because VT terminated during mapping and we actually did not terminate VT during the ablation. That was the only thing left. But I believe ILM map conclusively it correlated with the, it correlated with the site of isthmus. And both of these were adjacent areas, as have been described during by Dr. Stevenson as well as later on by other colleagues.
Did you sort of target particular area for this ILR mapping when you did that, or did you do for the whole LV and then targeted this particular area?
Sir, we had mapped actually. We had ILM map. Initially we were trying in sinus rhythm. We did for the whole of the LV, sir. Then sinus map, it was showing late potential, but they were very close to the close after the QRS, almost at the end of the QRS. So then we later on used RV pacing, which caused a significant delay that made them more discernible. And with RV pacing only, we mapped the whole of the LV. And on the septum, yes, sir.
Yeah, it's just an observation. You had inducible VT1 and VT2.
Yes,
but
sir.
If you sort of actually compare the morphologies, the VT2 is a close match, but not
yes, sir.
identical
yes,
to
sir.
your clinical VT.
Yes,
right?
Sir. Yes, sir.
Yeah?
Yes,
it is a close match,
yes,
but it's not.
It's
and
not,
also
yes,
when we sort of finally look at your ablation pattern, it looks more like a substrate modification rather than isthmus ablation. Do you agree, or you can disagree with me? But just looking at that, it looks like more like a substrate modification.
Yes, sir. We did more than what was required, and the main principal reason was that we did not terminate the VT during ablation. That was the principal reason, sir. it's always we felt it is better to err on the on the safe side, and yes.
Yeah, but you have very well highlighted the entrainment mapping, and that was very good. What you had showed, where you had captured the late potentials. I would like to ask Dr. Natarajan if he has any questions or not. We can move to the.
Dr. Jaskaran, was it a point-by-point mapping or a high-density mapping?
It was a high-density mapping with a grid, sir. But we usually go ahead with a manual annotation of all the points first up. We did with an HD grid, and we usually annotate points manually from the beginning as well. So it was not like auto mapping first up. We did manual mapping followed by the completion of the map.
Okay. And in one sentence, if you have to say what was done differently in this case compared to the usual post-MI SCAR VT, what will be your answer? Just one sentence if you have to say, to summarize, because I joined a little later, just to tell in one sentence, what is unique about the case that you did?
Sir, use of isochronal, we first highlighted the isochronal crowding areas, and then later on we confirmed that VT, the isthmus was adjacent to the areas of isochronal crowding.
Okay.
And yes, sir.
Okay. All right.
Yes, sir. Thank you, sir.
Thank you. We can move on to the next presentation, please.
The next presentation. A challenging case of atrial flutter and heart failure by Dr. Sam. Is Dr. Sam there?
I'm here. Good evening, teachers, friends, and colleagues. I am Dr. Sam Jacob Cherrimal, EP Fellow at Sri Cherrimal Institute of Cardiovascular Sciences and Research, Bangalore. I will be presenting a challenging case of atrial flutter and heart failure. For our patient, who was a 57-year-old male, a chronic alcoholic, who had developed progressively worsening dyspnea over the last 2 months, he first visited the hospital close to his house, where he was evaluated for coronary artery disease. His angiogram showed normal coronaries. He was diagnosed as non-ischemic DCM, and by the time he presented to us, he had already developed orthopnea and heart failure with function class 4. On examination, he had tachycardia, a high pulse rate of 140 beats per minute. The BP was 110 by 60 millimeters mercury, and chest had bilateral ghost crepitations. This was a presenting ECG. It showed a heart rate of around 150 beats per minute. We can see a PVS right in the middle of the two QRS complexes. So following the big two, we suspected an atypical atrial flutter with 2:1 conduction. His echo showed global hypokinesia with LV dimensions being diastolic 52 millimeters and systolic 46 millimeters. He had severely depressed cardiac function with an EF of 20%, mildly dilated LA of 49 millimeters with moderate MR, moderate TR, and moderate PH with PHP of 40 millimeters Hg. He had dilated and non-collapsing IVC. To see if he had any other cause for his dilated cardiomyopathy, we also got an MRI done for him, which showed a mid-myocardial scarring, but he also had normal LV dimensions with dilated atrium. His EF was only 25%. So a differential diagnosis for this cause of heart failure was down to 2, being tachycardia-induced cardiomyopathy or alcohol-induced cardiomyopathy with atrial flutter. So we decided to take him for an EV study, and the initial EVM showed a tachycardia with a CCL of 240 milliseconds with the earliest activation from CS 910. So we entrained after this from CS 12 and CS 910. The entrainment of CS 12 showed a PPI minus TCL of 345 minus 240 and a PPI minus TCL of 250 from minus 240 from CS 910. We then proceeded to entrain from the RA and CTI. Entrainment from CTI regions from 5 o'clock tricuspid angles and 10 o'clock tricuspid angles showed a short PPI minus TCL, while entrainment from the RA lateral wall showed a longer PPI minus TCL. We then proceeded to map the RA using 3D carto, and this is the propagation map that we got. The propagation map is clearly suggestive of a classical counterclockwise CTI flutter. These are the different views of the CTI flutter. We then proceeded to draw a CTI line. And as we complete the CTI line, the activation pattern of the tachycardia changed along with the tachycardia cycle length. The tachycardia cycle length increased from 240 to 270 milliseconds, and the earliest activation was now from CS78. But we still had to learn to focus on the RA, so we again entrained the flutter from CS910 and CS12. But this time, the CS12 had a PPI minus TCL of 310 minus 270, and CS910 had a PPI minus TCL of 350 minus 270. So we then suspected it to be a LA flutter and proceeded to do a transeptal puncture. After the puncture, we again entrained from the lateral mitral annulus and the left atrial groove. The mitral annulus PPI minus TCL was 330 minus 270, while the LA groove PPI minus TCL was 290 minus 270. The last part that we entrained was the LA posterior wall, which showed us concealed fusion with PPI minus TCL of 280 minus 270. But we also had multiple fragmented pieces of the posterior wall, which is shown by this arrow. And then ablation of the posterior wall terminated the atrial flutter. We then proceeded to continue ablating all the areas that showed this kind of a fragmented signal on the posterior wall. This is the propagation map of the LA flutter. First one being the AP view initially. This is PA view. These are the ablation points that we got. Post RFA, there was no induced tachycardia despite aggressive atrial pacing protocols. Patient on follow-up of 6 months is asymptomatic. There is normalization of LVEF to 60%. This is post-ablation ECG showing sinus rhythm, even at the end of 6 months. So tachycardia-induced cardiomyopathy is basically an atrial or ventricular myocardial dysfunction resulting solely from increased atrial or ventricular rates. There's usually no underlying heart disease, but cardiomyopathy can cause gross and microscopic pathological changes, which includes myocardial scarring. The importance of tachycardia-induced cardiomyopathy is that it is a potentially reversible cause of heart failure. There is no age regulation for this. It can also be seen in fetal life and may cause fetal hydrops. Any cardiac Any tachycardia may cause tachycardia-induced cardiomyopathy. Commonest is probably atrial fibrillation, followed by atrial flutter and atrial tachycardia. It is quite unusual with AVRT and ALRT. The permanent form of junctional reciprocating tachycardia can also cause tachycardia-induced cardiomyopathy. Frequent VPCs and idiopathic left ventricular tachycardia too can cause tachycardia-induced cardiomyopathy. The extracardiac causes like paratoxicosis and glucogonoma may increase the heart rate and cause tachycardia-induced cardiomyopathy. Coming to LA flutter, it is seen less commonly than CTI flutter and atypical RA flutter, and so has been less described. It usually occurs with a structural heart disease. It is the most common form, involves a perimitral circuit, shows considerable anatomic variability with circuits around the PV osseous or LV septal wall, or having multiple loops. If the posterior wall is involved, there is usually scarring in that area. The ECG characteristics of LA flutter is like in our case, they tend to have broad upright flutter waves in V1, with either an upright wave in inferior leads or isolated waves in all other leads. And owing to the atrial disease, longer cycle length with a greater isometric interval between flutter waves may be seen. And because of this, it can mimic atrial tachycardia. So in conclusion, atrial flutter is a common cause tachycardia-induced cardiomyopathy and is difficult to be managed medically. Multiple flutter waves may exist in the same patient, and one of the most effective ways of reversing tachycardia-induced cardiomyopathy is by catheter ablation. Thank you.
Thank you, Dr. Sam, for that presentation. We'll move on to the next presentation by Dr. Arun Gopi on a post-surgical atypical LA flutter, critical isthmus identification and ablation. And then we'll have a discussion with both Dr. Sam and Dr. Arun. Over to Dr. Arun.
Everyone, a warm good evening. At the outset, I would thank Ashish sir for the opportunity to present two cases of post-mitral valve surgery, double loop LA flutters, the role of high definition mapping in identifying the critical isthmus, and how I dealt with these two cases. So the first story is of a 55-year-old gentleman underwent closed mitral valvotomy for severe mitral stenosis about 20 years back. Return hospitalization with tachycardia after that, multiple cardioversions done for tachycardia associated heart failure, put on amiodarone, diltiazem, digoxin for incessant atrial flutter, absolutely no response to medical therapy. Echo showing no significant mitral valve disease, but a huge left atrium of 54 millimeters with a normal LV function. In view of incessant atrial flutter, refractory to medical therapy, and recurrent heart failure, he was referred for radiofrequency ablation. And he was brought lab in tachycardia as well. You can see that the flutter waves were negative in lead 1, 2, and AVF positive in V1 and almost isoelectric in the mid-cardial leads to negative in V6. On given intracardiac, you can see that the A's are more than V, cycle lengths of 360 milliseconds. The CS activation is near simultaneous with approximate to distal timing. The activation mapping sequence, the activation mapping was done with the H-heated 18 electrodes. The electrical reference and anatomical reference was CS56. The cycle length was 360 milliseconds, and the mapping window was minus 180 to plus 160, which was almost 90% of the cycle length. The procedure was done under GA. T was done to rule out LA or LA appendage clot. We had a radial hemodynamic monitor, radial artery for hemodynamic monitor, right interjugular axis for an epipolar in the coronary sinus, which was the anatomical and electrical reference. Right femoral venous axis, 8 French for the transeptal axis, and the mapping was done with H-heated advisor H-heated catheter. Left femoral axis, 10 French long sheet for the intracardiac echo, which was a St. ICE catheter, and ablation was done with a flexible DF curve catheter. So mapping of the right atrium code that it covered only 40% cycle length. So mostly earliest was on the septum and CSOs, indicating that it was predominantly a circuit in the left atrium. And on the left atrium, the axis was taken with transeptal axis was taken after full heparinization with intracardiac echo evidence, and so no aortic reference catheter was used. SL0 sheath with the BRK needle, and the puncture was achieved with electrocautery 40 volts cut, and subsequently exchanged to Agilis, put on continuous hep saline infusion, and the HD grid was used to map this huge left atrium. You can see on this image how much of the atrium the HD grid can cover. The HD grid is very traumatic when safely taken. It looped around the left atrium. The LA was huge, and the ACT was kept between 350 to 400 throughout the procedure. In such a huge left atrium, HD grid helped us in achieving good contact, and it completed the activation map. And in a huge left atrium, point by point map would have been a disaster. And mapping clearly showed that almost 95% cycle length was covered in the left atrium, with the right atrium being already passively activated. And we had beautiful signals from the HD grid. The voltage definition was the low voltage ID was 0.1 millivolt, and we found two areas of scar at the posterior left atrium, one near the right superior pulmonary vein and another near the mitral annulus. These were probably the surgical entry scars, and in between these two scars, we really found excellent fractionated signals that was shown by the HD grid. You could see that at this site between the scars, you could really find beautiful signals, low amplitude, fractionated signals, which covered almost 290 milliseconds of the entire 360 milliseconds of the tachycycle, indicating that this was definitely the critical isthmus. And below the isthmus, you could find split potentials on the HD grid, which were separated by a very good isoelectric line indicating scar. And this is the propagation map, which clearly shows that this is a dual loop, a figure of 8 flutter with a common isthmus between in the area between the two scars. So this was clearly a figure of 8 dual loop flutter with a common isthmus between the scars in the posterior left atrium. And so once this was identified on high definition mapping, the target was very clear. We wanted to connect these two scars, and this was the planned line of ablation. And once we took the ablation catheter there, we found the advantage of the HD grid. Just have a comparison with the signals from the ablation catheter and the HD grid at similar gains. A lower panel shows the ablation catheter signals. You could hardly find any signals from the ablation catheter. At the same time, HD grid with 1 mm electrode, 3 spacing, the biplanar recording, that is a recording in two orthogonal planes, helps in identifying these beautiful signals, which clearly made the mapping, made us understand what critical isthmus is. If we had done mapping with an ablation catheter, 4 mm electrode, 2 spacing, which looked at only one direction, we would have clearly wrongly designated these areas as scars because we could hardly find any potential there. HD grid made us understand that we had these fractionated signals and which covered almost 80% of the cycle length in that area. And once we had this all identified with high definition mapping, almost a point ablation in this critical isthmus terminated the flood immediately at 25 watts, 43 degree irrigated ablation, 17 ml flow per minute, monitoring the esophageal temperature. So you can see on the lower panel the flutter terminated to sinus with a point ablation in the critical isthmus at 35 watts. And this is the ablation. Post-in ablation was done at the Agilis sheet support and accessibility DF curve. And post-RFP, we found that the area didn't capture and were double potentials, ensuring that the lesion was complete. And post-ablation, on aggressive induction, burst up to 200 milliseconds and 2 extras. We could not induce any tachycardia. There was no documented TF, and so pulmonary isolations were not done. And the patient was shifted out of lab in sinusosome, is doing quite good on clinical follow-up in sinusosome, off antitherapics, and doing absolutely good on follow-up. The second case is in the post-MB repair. Again, similar clinical scenario, medically refractory atrial flutter, again, brought to lab flutter waves being positive in the inferior leads and in body leads, positive into 3 AVF and V1 to V6, incessant tachycardia, refractory medical therapy, recurrent heart failure, post-mitral repair. The tachycardia cycle length was 29 milliseconds and actuation pattern was distal proximal CS. And again, similar voltage settings, 0.11 millivolt low voltage ID for 2 scars, one in anterior mitral annulus and one in the posterior LA near the right superior pulmonary vein. And 95% cycle length was covered by the left atrium. This was again a dual loop flutter with one loop the anterior LA and one other loop the posterior LA around the surgical entry site scar. So this is the propagation map which shows dual loop, one loop going around the anterior left atrium and other loop going around the posterior left atrium between the surgical scar and the right superior pulmonary vein. So we strategically planned two lines, one line posteriorly between the RSPV and the scar, and one line anteriorly connecting the right superior pulmonary vein to the anterior mitral and annular scar. So once we did the posterior line tachycycle and change from 290 to 320 milliseconds, the change in atrial activation pattern, and subsequently when we did the second line connecting the right superior pulmonary vein to the anterior mitral annulus, the flood terminated to sinus and occupation of the second line. When we had such a long linear line, and position or tracking facility was used to ensure that the leaf was stable, and auto track showed we had stable continuous lesion since it was delivered using adjusted sheet support and using a flexible bidirectional ablation theater. So to conclude, post-surgical left atrium is definitely straight for left atrial flutter. Large atrium might not indicate that there is an extensively scarred left atrium. It might be because of some instance tachycardia leading on to atrial myopathy. Most of these atrial flutters are instance and refractory to medical therapy. The advisor HD detector is absolutely automatic, ensures excellent contact, and helps us see sometimes what conventional mapping detectors or ablation detectors fail to show, since it is able to record in two absolute perpendicular orthogonal planes. High density mapping is very useful in identifying critical isthmus, and sometimes even makes the ablation almost to a point focus like in case 1. And precision auto tracking facility ensures that the stability of the tech during linear lesion, and post-surgical dual loop LA flutters can sometimes be ablated from the common isthmus with the point ablation, or sometimes may require two linear lines. So thank you for the patient hearing, and that's from my side. Thank you.
Thank you, Arun. So the first case was by Dr. Sam. Is Dr. Sam there? Is Dr. Sam there? Can you unmute yourself? Yeah. So you presented a case of RA flutter and LA flutter, right? So you said during the ablation, the flutter pattern of atrial activation as well as the cycle length changed. So the shorter cycle length RA flutter, in your opinion, was suppressing the LA flutter, which became obvious when the RA flutter got terminated. Is that what you propose?
Initially in the first ECG, if you look at the ECG,
I can't hear you. I think Dr. Venkat, can you hear?
Well, I think his camera froze for a second, but
that's right. Okay. Go ahead, Dr. Sam. So my question was, my question was, while ablating the right atrial flutter, which had a shorter cycle length, and when that terminated, you had a slow flutter manifesting, isn't it?
Yes, sir.
So the faster atrial flutter was suppressing the slower flutter on the left side, right?
Yes, sir. In the on procedure, sir. Yes, sir.
Okay.
I was saying that if you look at the ECG, it looked like an atypical flutter and didn't look like a typical CTF flutter. So we had taken him suspecting something else, something which is not from the CTI, but on table, it turned out to be CTI suppressing the LA flutter, followed by getting him the LA flutter. So that's what happened on table. Yes.
How common is LA flutter in structurally normal hearts? See, the next presenter, Dr. Arun, both these cases had either a mitral valve repair, the other case had a closed mitral valvotomy, some cases with prosthetic mitral valves. So left atrial flutter is a disease of diseased hearts, left atrial flutter. Sir. So in the literature, you must have reviewed the literature. How common is LA flutter in patients with a simple flutter with a structurally normal heart, go on to develop tachycardiomyopathy, the way you presented your case? How common is LA flutter?
It is very, very uncommon, sir. If for a with a normal heart, structurally abnormal hearts, quite common, as you already specified, sir. It is usually if you do have a posterior wall scarring with no other structural heart disease, you're supposed to look for some other kind of restrictive cardiomyopathy in its initial stages, sir. That's the reason we got an MRI done also. But the MRI as such didn't show anything much. So we ended up thinking it's just tachycardia-induced cardiomyopathy, sir.
And your mapping was point by point mapping, or you used some multi-electrode catheters?
We use point by point, sir.
Okay. What is the equivalent of the HT grid of Abbott? What is the multi-point mapping that you have with your system? Is there any multi-point mapping system
as
available?
Of now, we don't use a multi-point system in our hospital as of now, sir. But we do sometimes get Pentarray, but that's not the usual one that we normally use. We normally use point by point smart touch.
How many points were mapped on the LA, roughly?
I don't remember the exact number, sir, but usually it is around 700 to 800 points minimum. It does go up to 1,000, 1,500, 2,000, and sometimes it depends on the LA size.
So must have been a pretty long procedure, right?
Which is why, so we actually at one point thought of doing the PVI also because of his heart failure being there. But the procedure had already taken a long time, so we decided not to go ahead with the PVI. Just connected to the left pulmonary veins and decided to stop the case, sir.
That was a very nice case. You clearly demonstrated the pattern changing, the cycle length becoming longer. You demonstrated nice entrainment figures from multiple crucial sites, and you did it very methodically, and both flutters terminated. And it was very rewarding to see that the LV function improved. So proving the fact that it was the tachycardia which was the cause of the LV dysfunction. So nice case, nice presentation. Congratulations. Dr. Venkat, do you have anything to ask Dr. Sam?
Yes, just one question, Dr. Sam. I think it's a very nice case, as Dr. Natarajan said. I mean, in your reply, you said that you were going to do PVI, but because of the time, you did not do the PVI. But in the case, you did not show us whether the pulmonary veins were active, or did you interrogate the pulmonary veins?
We did we interrogated the pulmonary veins, sir. They were not active. There's no pulmonary vein triggers as such. But because of his LA being mildly dilated, around 49 millimeters as specified, with an LV function being low, there was a chance that he might develop AF in the future. So as a preventive feature,
I'm not entirely sure about the thought process. If the PVIs, if the pulmonary veins are not active, with an assumption that they would be sort of active in the future to try and do a pulmonary vein isolation.
So that's
I don't
why
know what does Dr. Natarajan feel about that.
I would have stopped with the flutter ablation.
That's why we stopped with the flutter ablation.
What did you do, Dr. Venkat?
No, I mean, I would not go ahead and do PVI in this situation.
Absolutely.
Yes,
it was such a great result. You terminated one flutter followed by the other flutter. I would have called it a day, and if there is atrial fibrillation, we'll do it as a second procedure some other day. That would be my thought process too. Yeah. Anyway, excellent presentation. Congrats once again, Dr. Sam. So moving on to Dr. Arun Gopi. Arun? Dr. Arun, can you hear us?
Yes, sir. Yes, sir.
Yeah. So you are back in the cath lab ablating now. Okay. So nice case, nice presentation as usual from you. You showed two cases with mitral valve disease, one after closed mitral valvotomy, the other following a mitral valve repair, right?
Yes, sir.
Okay. We had the previous presenter saying that he painstakingly did point by point mapping of the LA, and he said some 1,000 points he normally takes. So you used the luxury of the HT grid catheter, and you so elegantly demonstrated. It was very fascinating to know that you ablated in a place where there was hardly any bipolar signal, right? In the first case.
Yeah, so the issue with the ablation catheter is if you're actually perpendicular, if you're in line of the electrical signal, you might not record it. With the grid, actually, we can actually push the grid in, ensure good contact, and with recording in two orthogonal planes, you'll actually get the actual signal there. So that is why grid was quite useful actually. With if we had done a point-by-point map of the first flutter, we would have actually labeled that area as scar, because we were not comfortable poking with the ablation catheter at that spot. Actually, with the grid, we are comfortable. We are pushing in and we are ensuring good contact in all spaces. When the grid flexes, we know you are in good contact, and that gives us the true signals in two orthogonal planes. Actually, so in that way, grid was useful for us, sir.
That is a nice demonstration of the bipolar not having a signals, but you ablated in a place where the conventional signal was not there, right? In that first case.
Sir. Yes.
You in one of the cases, you said you used an electrocautery for septal puncture.
Yes.
Why did you have to use electrocautery?
Sir, of late, we have been doing electrocautery for most of the transeptals. The advantage what we have found is there's no force required. Only disadvantage we found is sometimes when we just use 40 cut. Occasionally, we have had some amount of char at the tip of the catheter, but at the tip of the transeptal puncture needle. But with cautery, we don't have to use any force. We felt it is much safer to use cautery for transeptal actually, because we are doing eyes guided.
How do you do it? How do you use the talent?
So we find that on the eyes we have good tending, and once you have found the place with good tending and at the site of the required transeptal, just apply electrocautery 40 watts cut. The moment you apply 40 watts cut, the needle just goes in. It's like a smooth cut. It will just go in without, there's no force required. It will just go in a millimeter inside. That's also.
But we have been doing countless numbers of PTMC with enough force.
Yes, sir,
Dr. Venkat, what's your experience? Do you also use electrocautery for septal punctures for your PVI cases?
No, I think, I've seen, I've scrubbed in cases where electrocautery was done, but that was mainly for repeat procedures where the septum was either very thick or if there was a problem with the normal transeptal. So not routinely for all the cases, I would have thought.
And Arun, you did mention about surgical scar in the second case, didn't you?
Yes, sir.
What surgical scar for a mitral valve repair? What is the usual surgeon's approach to the mitral valve? Is it do they do a incision in the atrial septum and go to the other side, or what do
they access the left atrium. Discussed with my surgeon. They access it near the right superior pulmonary vein, and then they go into the LA to repair it. So that area is where the scar was actually near the right superior pulmonary vein and access to LA, sir.
Okay. So nice demonstration of the use of HT grid catheter.
Sir, if you want, sir, if you have time, I can just share a video of this cautery. This thing. It is nothing like I have to share, because this is, if you can see that, sir.
Yes.
Can you see that?
Yes.
So the needle is at the point where it is tenting, and once you apply cautery, just a millimeter goes in. There is no force, nothing actually.
Okay.
So it's extremely safe, sir.
Any specific preferred location for septal puncture in patients with suspected left atrial flutter? How in comparison to a left-sided accessory pathway or percutaneous mitral valvotomy, let us say? Are there any specific places where you would prefer puncturing the septum?
So always posterior, sir. Posterior, slightly inferior. We have better access to all pulmonary veins actually. Okay. And for otherwise, for PTMC and all, we prefer slightly anterior puncture for even the pathway, but this is more posterior punctures.
All right. Dr. Venkat, you want to ask Dr. Arun any questions?
Yeah, it was a very impressive presentation of two very rare cases, not that we commonly see. But you said that you used a esophageal probe as well. Is that something that you sort of routinely use for all the cases?
Sir, for all left atrial ablations, we have an esophageal temperature probe kept in. And whenever if you're ablating the posterior wall, we always pull in the esophageal electrode at the site of ablation and ensure that we stop ablation the moment temperature rises. Any posterior relay ablations, we have esophageal temperature probe kept in.
That's good. Thank you. I don't have any more to ask you.
Thank you, Dr. Sam, as well as Dr. Arun, for this very enlightening presentations. Thank you.
Thank you, sir. Thank you.
Thank you to the judges, and thank you to all our presenters.
Amey?
And I request the judges to send marks. Can you hear me?
I can. So Amey, can you hear us? Can you hear me?
Yes, I can. Yeah.
Okay. Nice to see you after a long time. So what exactly do you want? You want us to independently?
No, basically, independently, both of you have to actually give marks out of 10 for each presentation. And then by like presentation 1, this is the mark, presentation 2, this is the mark, and then just WhatsApp it to Ashish. So we collage that, and then accordingly we decide.
Okay. Doctor, thank you.
All the presentations all the presentations of all these exhibition halls, there are almost 70-80 of them. So we are giving marks as per the judges, and then we are having prizes for them.
So we need to send it by WhatsApp to Dr. Ashish.
Yes.
Okay.
Right.
Anyway,
Correct.
thank you very much,
Yes.
Dr. Amey, for that wonderful conference that you are coordinating. And
Thanks, Dr. Amey.
congratulations to you.
Thank you.
And Dr. Venkat,
Thanks.
thank you very much, and nice seeing you online. We'll meet sometime in person in the future.
Yes.
And I once again apologize for having held up in an emergency unexpectedly. So
Thank you. Thanks for joining.
No problem.
Thank you.
Thank you.
Bye.
Thanks a lot.
Bye.
Bye.